Hello, and welcome to today's webinar entitled Pharmacological Treatment of Residual Sleepiness in Obstructive Sleep Apnea, an important indication for wake-promoting drugs. My name is Gary Zamet, President and CEO of Clinilab, and I'll be the presenter today. Before beginning, I'd like to thank all of you for taking the time to join today to listen and participate in this webinar regarding wake-promoting therapeutics. The objectives of this presentation are to briefly summarize data related to the prevalence of residual excessive sleepiness, or RES, in obstructive sleep apnea patients treated with nasal CPAP, identify predictors of RES in OSA patients treated with nasal CPAP, review risks associated with RES, discuss treatment approaches to RES, and finally, review clinical trial data from studies of pharmacologic treatment of RES in OSA patients treated with CPAP. And as a brief disclosure, I have received research support from industry sponsors that have developed or that are developing wakefulness-promoting therapeutics. Before I get into the presentation, I'll ask a few polling questions. And for those of you who are able to respond, please do. What is the prevalence of residual excessive sleepiness in sleep apnea? Less than 10%, 10 to 25%, 25 to 50%, or greater than 50%? 2. Do you believe that residual excessive sleepiness should be treated? Yes or no? And 3, is residual excessive sleepiness an appropriate target for drug treatment? Yes or no? Let's begin by talking about the prevalence of residual sleepiness in OSA. The overall prevalence appears to be high. This epidemiologic study by Pepon examined 502 patients from 37 sleep centers across France. In order to participate in the study, subjects had to have an AHI of greater than 10 prior to commencing CPAP treatment, had to be treated with CPAP for 1 year, and had to be compliant with CPAP as defined by the French National Health System, which is CPAP use greater than 3 hours per night. For those of you who are unfamiliar with the term AHI, that is the apnea-hypopnea index, or the average number of apneas and hypopneas that occur per hour of sleep. CPAP, of course, refers to continuous positive airway pressure treatment, which is the most common treatment for obstructive sleep apnea. The assessments included in this particular study were the polysomnogram, the Epworth Sleepiness Scale, depression scales, and quality of life scale. The authors found that 12% of their sample had residual excessive sleepiness. And after controlling for potential confounding factors, such as RLS, depression, and narcolepsy, the authors still found that 6% met their criteria for RES. When they examined the report of unrefreshing sleep, 37% of those with RES reported such, while only 7% of those without residual excessive sleepiness reported such. And when examining daytime fatigue, 33% of those with RES reported it, while only 5% without RES reported it. Okay, one might argue that patients included in the Pepon study were not adequately treated. After all, they had to have only 3 hours or more CPAP use per night. So one might argue that these patients don't represent an appropriate sample in which to examine RES. Well, Weaver and Associates examined 149 patients between the ages of 21 and 60 who had obstructive sleep apnea with a baseline AHI of at least 15. Patients in the study were effectively treated with nasal CPAP according to clinical assessments, and all demonstrated at least a 50% decline in AHI at the time of CPAP titration. The authors examined patients using tests that included measures of objective and subjective daytime sleepiness and functional status. What they found was that 22% of patients who used CPAP 6 or more hours per night reported excessive daytime sleepiness. 52 patients who used CPAP 6 or more hours per night had objective evidence of sleepiness on the multiple sleep latency test, or MSLT. For those of you unfamiliar with the MSLT, it is an objective measure of sleepiness in which patients or subjects are given the opportunity to nap multiple times during the day, usually at 10 a.m., noon, 2 p.m., 4 p.m., and possibly 6 p.m. And the EEG is used to determine how long it takes the patient to fall asleep from the time the test begins until the time the test ends. So 52% with objective evidence of sleepiness on the MSLT, and somewhere between 27% and 67% had abnormal FOSQ scores at post-treatment assessment. That's the Functional Outcomes of Sleep questionnaire that examines functioning in patients with sleep apnea. The authors noted that there was a dose-response relationship between FOSQ scores and CPAP use. Now, an even greater prevalence of RES in obstructive sleep apnea is suggested by Souralakis and associates, who examined 208 patients with obstructive sleep apnea who used nasal CPAP for greater than 4 hours per night for 6 months. Subjects in this study could have had a number of comorbid conditions which were not exclusionary. Following CPAP treatment, 114 patients, or 55% of the sample, had an Epworth sleepiness score greater than 10. These individuals were considered non-responders to CPAP treatment. When a multivariate logistic regression analysis was done with these subjects only, it was found that predictors of RES were history of depression, diabetes, heart disease, higher Epworth Sleepiness Scale scores at baseline, and lower respiratory disturbance index, or AHI, at baseline, all predicting residual excessive sleepiness. So back to our polling question at the beginning of this presentation, I asked the question, what is the prevalence of residual excessive sleepiness in sleep apnea? Less than 10%, 10 to 25%, 25 to 50%, or greater than 50%? We see studies showing a variety of results. So virtually any answer that you gave to the polling question would be correct. However, it does seem that the prevalence of residual excessive sleepiness is higher than what might be expected. The trends in the data that have been collected thus far suggest that this is a common problem. Now, why is residual excessive sleepiness important, and why might it be a target of treatment? That is because daytime sleepiness is associated with impairment. It's associated with general impairment in daytime functioning. It's associated with cognitive impairment, such as compromises in attention, concentration, memory, and ability to stay on task. It's associated with psychosocial dysfunction, with reduced quality of life, with increased accident risk, both occupational accident risk and motor vehicle accident risk. And there are even some data indicating that daytime sleepiness is associated with increased cardiovascular risk. So if a patient with obstructive sleep apnea who is treated with nasal CPAP and adequately treated continues to experience excessive daytime sleepiness, that patient remains at risk. Now, Now, there are a number of ways that residual excessive sleepiness can be treated in sleep apnea. One is by sleep hygiene. The clinician, the physician or sleep specialist might consider how much time the patient is actually allowing for sleep. Is the patient getting a full 8 hours of sleep every night? Could that be a reason that the patient is experiencing daytime sleepiness? So sleep hygiene recommendations that ensure that the patient reserves enough time for sleep every night is an appropriate recommendation if the patient is not getting adequate sleep. Another approach might be to optimize CPAP pressure. One might consider that CPAP pressure may not be adequately addressing the respiratory disturbance that the patient is having during sleep. So retitration of CPAP pressure might be also an appropriate step. Ruling out comorbid conditions can be an important element of the approach to this problem. For example, the patient with obstructive sleep apnea may also have periodic limb movement disorder or restless legs or another sleep disorder. Having sleep apnea doesn't reduce the risk of having any other type of sleep disorder. So doing a thorough diagnostic workup to identify any other sleep conditions that require independent treatment might be appropriate. Promoting CPAP compliance is also an approach to RES in sleep apnea, making sure that the patient uses CPAP every night when he or she sleeps, and making sure that the patient optimally uses CPAP every night for the full night rather than just perhaps a few hours. So making sure that patients are compliant is yet another approach. And then finally, pharmacologic management of daytime sleepiness may be a consideration. Now, we've talked about titrating or retitrating patients with nasal CPAP. This study by Mulgrew assessed residual sleep apnea in patients treated with nasal CPAP. 61 patients with moderate to severe sleep apnea were treated with nasal CPAP and followed for 3 months. Their AHI was examined, and they were also tested using the Epworth Sleepiness Scale and the Sleep Apnea Quality of Life Index. 15 patients, or 25% of the sample, had residual sleep apnea with an AHI of greater than 10, which means that they still had sleep apnea. And the Epworth Sleepiness Scale score in these patients with residual sleep apnea was significantly greater than those who were effectively treated. And scores on the Sleep Apnea Quality of Life Index were worse in those with residual excessive sleepiness than in those who were effectively treated. So re-examining the patient's underlying sleep apnea and determining if the sleep apnea is in fact adequately treated or not with nasal CPAP can be an important approach to assessing and treating residual excessive sleepiness in sleep apnea. Now, there are also pharmacologic approaches to treating residual excessive sleepiness. In this study, Black and Associates examined 305 patients with obstructive sleep apnea from 42 sleep centers in the United States and Europe. All patients were using nasal CPAP according to a stable regimen for at least 4 hours per night, and they were required to meet CPAP effectiveness criteria during a pre-enrollment period. Patients were included if their AHI was less than 10 while they were on CPAP. Patients were excluded if they had low oxygen saturation, below 80 for more than 5% of the night, comorbid sleep disorders, other active medical conditions, or a history of alcohol or substance abuse or dependence. Patients were randomly assigned to receive placebo, modafinil 200 milligrams, or modafinil 400 milligrams in a 1:1:1 ratio for 12 weeks. They were instructed to take one dose daily in the morning. The Epworth Sleepiness Scale was administered, and the Maintenance of Wakefulness test was performed following 4, 8, and 12 weeks of treatment. The Epworth Sleepiness Scale significantly improved following 12 weeks of treatment with modafinil, showing a difference in mean scores from placebo of 4.5 points. The percentage of patients with an Epworth Sleepiness Scale score of less than 10 was 38% for modafinil 200 milligrams, 45% for modafinil 400 milligrams, and only 17% for placebo. The results of the Maintenance of Wakefulness test data are shown on the next slide. For those of you who are unfamiliar with the Maintenance of Wakefulness test, it's a challenge test in which the patient is placed in a darkened room and in a recumbent position and with EEG electrodes on and told to remain awake. Patients who are not sleepy at all are able to remain awake for the entire test period, which can be 20, 30, or 40 minutes, depending on the type of protocol that's being run. Patients who are sleepy will be unable to sustain wakefulness throughout the entire recording period, or they may fall asleep in 5 minutes or less, 10 minutes or less, 12 minutes or less, or thereabouts. So what you see here are Maintenance of Wakefulness test data. These are average scores. The test is done at multiple points throughout the day. So these are average scores obtained at baseline, week 4, week 8, and week 12. You can see that both of the active drug conditions, modafinil 200 milligrams and modafinil 400 milligrams, showed an increase in sleep latency. It means taking a little bit longer to fall asleep relative to baseline. And that's just visually determined. I'm not saying that that's statistically significant, but there's statistically significant separation between active drug and placebo at week 4, week 8, and week 12. So we see statistically significant differences from placebo between modafinil and 200 milligrams and modafinil 400 milligrams. Now let's take a look at the effects of modafinil on attention and quality of life. This study by Dingist and Associates examined the effects of modafinil 200 milligrams on obstructive sleep apnea patients with residual excessive sleepiness. The study examined patients with moderate to severe sleep apnea. That means they had an AHI of greater than 15, with residual excessive sleepiness documented by an Epworth Sleepiness Scale score of greater than 10. Patients had this presentation despite at least 2 months of CPAP use. The design included a 21-day run-in period during which CPAP use was monitored at home, followed by 2 nights of polysomnography, during which time CPAP effectiveness was documented in the laboratory. That was documented by an AHI of less than 10 and 50% or greater reduction in the AHI. In this study, 77 patients received modafinil and 80 patients received placebo. Modafinil was 200 milligrams during week 1, and then it was raised to 400 milligrams during weeks 2 to 4. And I'm sorry, I forgot to mention that earlier. So it started at 200 and then raised to 400. Assessment was done using the PVT, or Psychomotor Vigilance Task, which is a reaction time test. And PVT lapses in this study were found to decrease from baseline with drug treatment. The mean change from baseline in the CPAP plus modafinil group was minus 0.5, showing a reduction in lapses, while there actually was an increase in lapses to 0.11 in the CPAP plus placebo group. Similarly, there were statistically significant improvements in reaction time and in FOSQ scores at week 1 and week 4. And here you can see data from the study. You can see on the left graph FOSQ total scores at baseline in the CPAP plus placebo group and the CPAP plus modafinil group. But then if you look to the right of baseline, you see week 1 and week 4 data showing statistically significant better scores on the FOSQ in patients who were treated with CPAP plus modafinil. Similarly, if you look at the right graphs, you see baseline and week 4 data for activity on the left, and then vigilance on the right. And I apologize if those error bars are a little off center, but what you see is that at week 4, patients in the CPAP plus modafinil group had better scores on activity and vigilance than those in the CPAP plus placebo group. And these data, this graph represents a summary of median reaction time data on the PVT, which is that sustained performance task and reaction time task. And there you can see patients in the modafinil group significantly improved. Their reaction time got better. And patients in the placebo group, their reaction time actually worsened. And that difference is statistically different between modafinil and placebo. Now, the studies I've shown you thus far relate to modafinil. The existing evidence indicates that Armodafinil is effective as well. This study essentially replicated the Black and Associates design, assessing patients at baseline and at weeks 4, 8, and 12 with Armodafinil. Patients were randomly assigned to receive either placebo or Armodafinil with doses going up to a maximum dose of 150 milligrams once daily each morning. Now, in this study, the measures used were clinical global impressions, episodic memory, which involved word recall and picture recognition, and the maintenance of wakefulness test, which I described to you earlier. So let's take a look at the mean change from baseline in the quality of episodic memory. And you can see at week 4, at week 8, at week 12, and at the final visit, episodic memory is better in patients treated with Armodafinil versus those treated with placebo. Now, let's take also a look at 12-week open label study data. This study was to assess the efficacy and safety of modafinil to treat residual excessive sleepiness in patients with sleep apnea who regularly used CPAP. It was a 12-week open label study of 125 patients with moderate to severe OSA. They were studied after completing a 4-week double-blind study. And in order to get into the study, they had to have an AHI of 15 or more before CPAP treatment and an Epworth Sleepiness Scale of 10 or more before CPAP treatment. The results of this study show us that the mean Epworth Sleepiness Scale score improved at week 12 versus the end of double-blind baseline. Mean FOSQ score improved at week 12 versus the end of the double-blind baseline, and the percentage of patients who rated themselves as improved increased from 83% at 1 week to 93% after 2 to 12 weeks. The most common adverse experiences in this study were headache, anxiety, and nervousness. So there are data suggesting not only improvement on objective measures like the MWT, but on self-report measures, both for Modafinil and for Armodafinil, and also 12-week data, both double-blind and open label, indicating persistent therapeutic effects and an improvement over that 12-week period. Now, just to be a bit thought-provoking, I wanted to close with a couple of slides, and this slide I think is interesting. This is a study by Stradling in which post-CPAP sleepiness was assessed, and people with sleep apnea were compared to their partners who served as controls. So I'm presuming that most of the patients in this study were men, and most of the controls in this study were women. And the Epworth Sleepiness Scale was used to assess residual excessive sleepiness. And patients were on CPAP or AutoSet for more than a year. So what the author found was that of the 572 patients who were on CPAP for more than a year, 4.5% of them had an Epworth Sleepiness Scale score of 14, of more than 14. 16.1% had an Epworth Sleepiness Scale score of greater than 10. So, consistent with what we might have expected from the prior epidemiologic data showing that residual excessive sleepiness is there, of course. But then look at the control data. The controls, the bed partners who didn't have sleep apnea, presumably, 3.8% had Epworth Sleepiness Scale scores greater than 14, and 14.3% had Epworth Sleepiness Scale scores of greater than 10. The difference between the patients on CPAP and the controls is not statistically significant. So the question is it really there as a consequence of inadequately treated sleep apnea? So in summary, what I've attempted to do today is cover the topic of residual excessive sleepiness and sleep apnea. The prevalence of this problem appears to be generally high. It appears to be present when patients are treated with nasal CPAP and when that treatment is considered adequate. Some studies have identified predictors of residual excessive sleepiness in sleep apnea, and residual excessive sleepiness is believed to represent a risk to OSA patients who experience it. There are multiple treatment approaches to RES, including sleep hygiene, additional diagnostic work to rule out comorbid conditions, retitration on nasal CPAP, and pharmacologic approaches. The pharmacologic approaches to treating RES improve wakefulness, cognition, performance, and quality of life. Despite these advances, there's still some controversy regarding excessive sleepiness in treated OSA patients and the origins of that excessive sleepiness. RES may be an important drug target for the development of new therapeutics to help people with sleep apnea. Thank you very much. I will close here, and if you have questions, I'll be happy to take them. Thank you.